Welcome to Acute Conversations, the official podcast of APTA Acute Care, where we share engaging conversations about acute care physical therapy so you can connect to your profession. I'm Ashley.
And I'm Leo.
Today's episode was recorded live during APTA Acute Care's Bridge the Gap Conference in Chicago, May 2024. It features guest speakers and attendees sharing their insights about the conference. Enjoy the episode.
All right, we're here at Bridge the Gap 2024 here in Chicago. I have with me our keynote speaker, Dr. Patel. A quote that I really like during your keynote presentation is, bring the humanity back into intensive care. Can you explain a little bit about what that means?
Yeah, I think in the ICU, we really dehumanize patients. We don't let them be awake. We don't let them move. They're not wearing their clothes. We don't know their personality. They're on machines. They're not talking to you. And so it's really easy to not see them as people. And what mobility does is that when we awaken the mind and we make it move, then we can see them again. And it makes us realize that the effort or the risk that we took to get them out of bed was a way to actually know who they are and recognize that and honor that. And I do think our patients benefit from that because then they're less disabled and they can return to their lives. So I want to really push against the need to control, because I think when we try to control every aspect of the illness, we take away parts of the people we're trying to save. And in fact, we should preserve who they are, as they're fighting for their lives. So I don't think that we should dehumanize anymore. We should rehumanize our patients.
That's fantastic to hear. And I also am very happy that you were elected as our keynote speaker, because another one of your quotes is that you're a fan of physical therapy. So thank you for all that you do, and also all the research that you put out, and being our keynote speaker today. Thank you.
Thank you.
Awesome. With me now, I have two of our committee members that help put Bridge the Gap together. We have both Sue Griffin and Carrie Fuller. Thank you so much for being part of the group to help put this together. How's it been going so far?
I think really well. It seems like there's a lot of engagement with the session presenters. People are liking the topics. Right now, what's going on is people are having a chance to talk to the presenters, and I'm hearing a lot of active conversations. So that seems so far so good. The cookies are good. So
I also have to give a shout out to Nicole Neveau and also Carrie Fuller, who helped run this morning. So we got up at 6 in the morning, and we ran how many miles? 20 miles, was it? No, I think it was just 3 miles. But it was also a free tour because I grew up around Chicago, so I'm like, oh, it was a good time. Yeah. So how was the run this morning?
It went a little farther than I thought it was going to, but I made it back, and I made it to breakfast just in time. It's a bit more humid than what we're used to in Colorado, but it was beautiful. Lake Michigan is so beautiful, so I really enjoyed it, and I enjoyed the camaraderie with the other PTs and PTAs that came, so yeah. How's it been going so far with the education sessions? I mean, I was really interested in the curriculum mapping because I work in education as well, and it was just getting my mind going, thinking about what I teach, pathology, and if it should be before or after patient care skills, because I've always in my head thought of wanting to have it after patient care skills so that they have an understanding of pathologies and diseases before they're trying to move people, and ours is the opposite right now. So it just kind of got my wheels turning for how curriculum should be mapped out. It was great.
And everything can't be last in the curriculum, right? Everything, you can't wait for everything. So you just have to start with something and, like you said, try to build on it or integrate it. I thought that's what I liked about the curriculum mapping is it shows how it's very intentional about going back and reinforcing and building on previously learned skills.
Awesome. Well, thank you so much. Awesome.
Thank you.
All right, I am here with Timothy Murakami, who is a PTA, and I heard recently minted new PTA. How long has it been since your graduation?
Graduated in spring of last year, 2023. Yeah. Mm-hmm.
Awesome. So tell me, how's it been? So this is day number 2 of Bridging the Gap. Anything that kind of stuck out in your mind in terms of the different education sessions?
Yeah, I think the diversity of the education sessions has been paramount so far for me as a new clinician, and I want to continuously improve as a clinician so I can better serve my patients, and the different topics that are happening throughout the weekend, the tour, the keynote speaker, about ICU, and it's just the diversity of the topics has been really eye-opening for me.
So one of the things that we thought that was going to be really important about this conference was that we're going to give you information and education that you can use come Monday when you return back to the clinic or to the hospital. Is there anything that you learned that you're thinking, man, this is going to change my practice the day right when I go back to the hospital?
Yeah, so far what I've learned so far is from the ICU presentations, because where I work at Franciscan Health, we have a good structure in the ICU, but what I've learned so far, I would just love to be able to open up a dialogue with the staff there and just see what we can do to implement early mobility in the ICU. That's my first focus of going back and sharing that with my team and also the ICU team as well.
That is so cool. So hopefully we can implement some change starting here at Bridge the Gap. Thank you, Timothy.
Thank you.
I'm here with first-time participant at Bridge the Gap, Dan Milner. This is his first Bridge the Gap. Dan, how's it been going so far?
It's been exciting. Chicago's a great place. It's a collection of great minds discussing what we're doing individually and what we're doing as a profession and how to better it.
You know, it's great, too, because Dan is a fan of our Chicago lakefront because he went for a run this morning. I think we went 12 miles.
We would have had to start a lot earlier than 6 a.m. I'm sure there's some
6
gluttons for
a.m.
punishment that would get up at midnight to run 12 miles before, but not us.
But also, there's another Chicago connection because you have a colleague that you work with who is also a University of Chicago DPT grad, Lori, correct?
That's correct. The PT realm is small.
And I think that she's gone to CSM. She was actually on the podcast, and she's been sharing some information. What information that you've gathered from this Bridge the Gap conference are you going to bring to your clinic on Monday?
You know, when the presentations were announced, there was a lot of excitement where I work with high-intensity gait training, because that's like the buzzword that's been at our institution for a couple of months now. And Lori at CSM was at the Shark Tank and submitted a proposal for a high-intensity gait training and how we implement it at our hospital. And here's an organization that did it. They kind of started 2 years ago, and we've been doing this for several months. And so it's kind of like having somebody to help guide and direct us implementing our own program of their successes, their challenges, their equipment that they're kind of using. Just having other minds to bounce ideas off of and how we can be successful in our kind of local scene.
That's pretty cool. So would you say that we are bridging the gap between evidence and practice?
Evidence, practice, and amongst each other and as a profession, linking everybody together.
That's so cool. Awesome. Okay, I'm here with Shannon Possart, and we actually have a really cool story. Let me start off, though, that Shannon, you're not an acute care therapist. Is that correct?
That is correct.
Okay, but there's a reason that she's here at Bridge the Gap, and it starts off with how we actually met.
Okay, so I met Leo on the airplane back from CSM this year. I made a joke that I thought he was a student because he had like 6 Theracanes, and only students come back with 6 Theracanes. Yeah, I'm like, what's going on with this person? So we got to talking, and Leo had mentioned that he works at UIC, and we talked about my passion for teaching and how to kind of get into that setting. I'm currently an outpatient neurotherapist at Shirley Ryan, but I think in the long run I'd like to give back in some sort of educational platform. So Leo was like, hey, we have this conference coming up. Do you have any research from acute care? So I have my poster presentation on a quality improvement project that I did during my residency at University of Washington about the core set of outcome measures. And that's how I'm here. But I'm also learning a lot about acute care and education and meeting a lot of really cool people.
And I also think that, did you graduate from Emory University?
I graduated.
So one of the chair people that are helping us with Bridge the Gap is Kathy Lee. And so I do remember when Kathy said that your poster was accepted, it was pretty exciting.
Yeah, Kathy is the best. And I still might have PTSD from some of her classes, but I've learned a lot, and I have a real appreciation for kind of the spectrum of therapy across all settings. So it's really kind of cool full circle moment here for me.
I thought it was really interesting. We had this conversation too about, even though that you are in outpatient neuro, you see the deleterious effects of patients that have been in bed in critical care for a prolonged period of time. Is there anything that you've come across so far in the conference that's going to change your practice come Monday when you walk back into the clinic?
I think that's a good question. And I was actually reflecting on this during one of the talks about, how we don't get people up soon enough. And like you said, there's these long-term effects. So a lot of the patients that I work with have chronic illness. And so they're in and out of the hospital all the time. So I think something that I can take to my practice is educating my patients, like, hey, it's likely that you'll end up in the hospital again, given the diagnosis that you have or the treatments that you're going through. Here are the benefits of getting up early, and here's how you can advocate for yourself and, talk to your family about how they can help advocate for you, getting in touch with your PT that's consulted on your stay, so that in the long run, you're benefiting. So I'm hoping that I can bring that to all of my patients. Yeah.
Okay, I'm here with Archana and Elizabeth. You had just finished your presentation this morning here at Bridge the Gap. The title of it was Curriculum Mapping. So what I wanted to ask you is, why is this so important, especially for those PTs that work in academia? Why is this a salient topic and something that we need to really take a good look at?
Do you want to start?
All right. So thank you for the question. We had so many questions and interactions today with our session talking about curriculum mapping and specifically a medically complex patient. Mm-hmm. Because when we look at students coming out into the clinical force, are they team ready? Are they able to make clinical decisions? Are they knowledge-based and evidence practice, as we talked about early in our session? So we took some time to meet with everyone and give us lessons learned and some of the research we've done in curriculum mapping, but also the successes that we've had.
Right.
Archana, I'll let you speak on those successes.
So in academia, it's important to thread concepts and make sure that we're progressing it from knowledge to then case-based, and understanding clinical decision-making is essential for our students. Also to understand what faculty are doing in each of their courses and make sure that we understand and we're integrating those concepts and we have outcomes and assessments based on these very important topics. It's also a CAPTA accreditation requirement as well, and we all know that we need to do that.
There's an old PT adage: if it doesn't get measured, you can't improve upon it, right? One thing that's really cool is that right now we just finished the roundtable discussions, and you had a lot of good questions, a lot of people that came up to your tables to kind of discuss. Were there any really good discussion topics related to curriculum mapping from this kind of post-session discussion time?
Of course, all great questions. One I want to point out is a conversation we had about professional development and onboarding. I talked to a young woman who is in charge of a larger hospital district, but they have required onboarding and professional development, and how could we just map that? And how do we match that to the hospital outcomes, maybe measurements on medical error, but also focusing on the patient of some of the conversations that we're having from an interprofessional lens, how are PTs working with other healthcare professions, but mapping that professional development would really give them some great data, even for hospital administrators, but also for the participants in that professional development to kind of see the big picture of why they're in that class and what the next class is going to scaffold on.
So our table had a lot of interesting conversations. Some of it was equitable distribution in terms of even resources. How do we bridge the gap? Again, marketing the theme of...
Take my job if I bridge the gap.
How do we bridge the gap between our clinical partners and our clinical instructors and our students and the academic settings? So what are the resources that are available to our wonderful clinical instructors who are taking our students when, unfortunately, sometimes that can impact their billing and the time that they put in, and even after their clinical settings times? So what are some of the resources and some of the equity in terms of looking at how these two institutions institutions or two environments can work closer together. I think those were some of the hot topics that people had brought up, and a very, very interesting take on things. I think looking at advisory boards and how we can look at external stakeholders as well and bring in experts to give an objective view of if we're doing it from a qualitative and a quantitative process is very important as well.
All right, we're here with Kathy Lee Bishop at Bridge the Gap 2024 in Chicago. Kathy, how's it been so far?
So it's really exciting. We've had some great, robust discussions talking again about translating the evidence into practice and collaboration. And the last session, which was on just that, looking at data that was happening in acute care and translating it and making changes, it was just fascinating.
Yeah.
And it really engaged the whole audience. And they didn't want to leave. We kind of had to say, we've got to go to the wine and cheese and we've got to look at the posters, and there's going to be more discussion later. And so I really enjoyed that just the questions that came from the audience were beneficial to all of us.
Yeah, I felt it was more like a discussion rather than a lecture where the presenters were just kind of talking to the audience got engaged back and forth. Even the audience members were asking questions back and forth. That was pretty fun.
And it really seemed like it was therapists that practice in different settings, larger and smaller hospitals, as well as those of us that teach, to try and understand what do we want to teach our students about evidence in practice, not just taking evidence from school into practice.
That's right. So tell me, how did you get involved with the whole Bridge the Gap conference?
So I just found it fascinating of how the format was set up, that they meet every other year, that it has a theme, and the theme can be applied whether you're practicing as a clinician or that you're teaching, which is whether you're teaching as a clinical instructor or teaching in the actual classroom with students. And I really like that it's a very energetic, but small and intimate conference, so that you have an opportunity to network with others, as well as learn immediately from others and take a message home, whether it's to the hospital or to the classroom. So I really like that format.
Excellent.
I have with me right now Benny Thomas, who is also the APTA Acute Care Treasurer, and we're here at Bridge the Gap. She has a poster. We're doing the poster session right now. Can you talk a little bit about what you have on your poster presentation?
Sure, Leo. So what this poster is about is actually a result of a paper that I published in the Cardiovascular and Pulmonary PT Journal. And we looked at the effect of early mobilization in the population of patients who have had CABGs and who were admitted in the ICU. So in looking at that, what I found out was many of the studies were talking about the 6-minute walk distance and really didn't have a lot of discussion about other outcomes that are applicable to our profession. So the poster that I'm presenting today talks about some of the other outcome measures that are used in that population. So patients in the ICU post-CABG. And so looking at what other measures are described. And so, for example, we can look at their pulmonary functions. We can look at their dyspnea scale. We can look at their distance ambulated using a pedometer. So it doesn't necessarily have to be for 6 minutes, because not all patients are able to do that, especially in that population. There's heart rate variability that's being tracked. So there are multiple things that are more relevant to us clinicians as PTs. So that is what my poster is all about.
Very cool. Now, as a CCS, you talk about heart rate variability. What can we say to the audience that's out there that might be working with patients that have CABG? What are some maybe good outcomes that you would recommend for them to use with their patients?
So it is going to depend on how your clinical presentation is from your patient, but my recommendation would be to track what is important to that patient based on their diagnosis and based on how they're presenting that day. So that might just mean that you're looking at the DOE. That may just mean that you're looking at their tidal volume, maybe pulmonary, the measures that you want to look at are the volumes and, how they are functioning. Oxygen saturation, for example, how quickly are they compensating for the decompensation that they just had from the very minimal activity that they had. So these are all measures that you can track and document and, really have an impact on how patients perform and how your discharge recommendations will be.
Hopefully those of you that are listening to the podcast or watching the podcast can start implementing some of these outcome measures with your CABG patients. Thank you so much. All right, I'm here with Bridget Nealon, who just presented here at Bridge the Gap Saturday afternoon. And I have to say, it was pretty engaging. I think you get the award for the most engaging presentation because you had everyone all up in arms and all the participants they had a lot to discuss. Can you talk a little bit about what your presentation was about?
Absolutely. So we were looking at Christ Hospital, Advocate Christ Medical Center. We did a pilot study with 4 units to really see if we could progress the AMPAC score for our patients and progress their functional outcomes to help discharge them to a lower level of care and also decrease their length of stay. You know, when we started this project, we talked about different hypotheses of what we thought would help this. One was being able to treat the patients more. A big thing was we were kind of stuck in this consultative culture, right? We had a high volume of evaluations. We were getting pulled to see patients for updated notes, for SAR authorization. And, you know, I think most of us got into this profession to, you know, intervene with our patients, to provide treatments and see them get better. Right. And our therapists wanted to do that, but I just didn't feel like we had the structure to be able to get back to our patients enough to progress them. So really we wanted our patient outcomes to be better, and we did end up using AMPAC as that tool to measure that. But it was also there was so much more to it than just the AMPAC score of it. Right. It was also looking at best practice, you know, again, looking at our intervention strategies, looking at our co-treatment rates, which is a very hot topic.
That's a very hot topic. So I think you said that your co-treatment rates went down, correct? Between PT and OT, correct?
Yeah, so when we started this, we were at 67%. So over 2/3 of the time we were co-treating. And by the end of this pilot project, we were down to about 25%. You know, and I think a big thing for the team when we talked about it was really kind of putting into perspective of, if your frequency is 5 times a week for PT and 5 times a week for OT, if you're co-treating each time, that patient's getting therapy 5 times. Wow. But if you're doing 5 sessions of PT and 5 sessions of OT, they're getting 10 sessions. Exactly. You know, so who is that impacting? It's the patient. And I also think it's allowing the therapist to treat to the top of their license. Right. You know, it is not a skilled need for me to have an OT untangling lines or doing line management. You know, they need to be in there working on the ADLs and progressing the patient. So, you know, not saying that co-treating is never appropriate. It definitely has its place, but there were so many opportunities when we started at a 67% co-treatment rate. So yes, throughout the course of this, then we saw that down 25%. So again, we're thinking about increasing the frequency of our patients. We're thinking about providing high-value evidence-based interventions to them, and that's what's going to help demonstrate that progress as well.
That's awesome. You know, I think a lot of therapists out there can relate to just being consulted only to do evals and not getting an opportunity to actually really work with their patients, follow up with their patients, even though in acute care there's short length of stay. Now, another thing that I thought was really interesting is what you said in terms of maybe communicating to the executives of some of these hospital systems what value we bring to the table. Can you talk a little bit about that?
Absolutely. So I also work in IRF as well. So I feel like IRF, we have outcome measures. Outpatient, we have several different outcome measures. In acute care, we didn't really have a good way to track our patients' progress. You know, so we wanted something that was valid in the acute care setting, which the AMPAC has shown validity in the acute care setting. We wanted something that the therapist, and if other members of the care team eventually wanted to perform it, such as nursing, would be able to carry out this measure as well. And that was a way then we could track our patients' progress through that, and then go to executive leadership and show them the numbers and say, you know, when we were able to see these patients, they went from this AMPAC score to this AMPAC score. And because of this change, we were able to get patients from a lower level of care. So some of those SNF recommendations we were making, because we were able to see them and progress them on the unit and not just be this consultative service, but truly treat and intervene on the acute medical floor, they were then able to discharge home versus to SNF, which then also we discussed, we looked at our averages of the average length of stay of a patient in a hospital that has to go to SNF versus that goes home with outpatient versus home with home health. So if you go home with outpatient, your average length of stay at Christ was 7 days versus going to SAR was 14 days. So we knew that if we could get them to a lower level of care, that would also help decrease their length of stay. Because there were certain bottlenecks, you know, when a patient is discharging to SAR. Some of it is just the medical complexity that they're going to have those longer lengths of stay. But it was also a family deciding on a SAR, getting insurance authorization. It was just adding days onto patients' length of stay. And again, not that some patients don't need SAR or SNF, but if they're kind of those patients that could progress to a point where they could go home, let's intervene on the acute floor and not just, again, be that consultative. We've made our discharge rec. Here we go. So really getting back and being able to progress that patient. So AMPAC was the tool that we selected, to really quantify our progress to executive leadership, because we can come with all our thoughts and feelings of, we feel our patients are getting better, but unless we have that quantitative data behind to support it, it's not going to go anywhere. And I think one of the biggest wins during this pilot is we were awarded 4 more PT FTEs because of the quantitative data we brought forward. And we were able to make that argument that, by increasing the frequency, we were going to progress the AMPAC, progress the patient, get them to that lower level of care, and decrease length of stay.
It was really cool is I heard somebody, I forget who had mentioned it, but this concept of rehab in place, right? Let's bring rehab to the patient. They're here, they're on the acute medical floor. Let's provide the treatment and not wait, or let's not just evaluate them and just kind of wait for a discharge plan and move on to the next evaluation. And then just for clarification, SAR, subacute rehab, SNF, skilled nursing facility, right?
Correct.
And then I think IRF, inpatient rehab facility.
Inpatient rehab facility, yes. Sorry.
No, not a problem. It's like, that's the lingo that I know exactly what you're talking about, just for our listeners, just that you all understand in terms of discharge planning. But all right, I have with me Ryan Fox, student from UIC. Ryan, this is your first Bridge the Gap conference, correct?
Yep.
Okay, how was it?
I really loved it. I learned a lot about acute care because I did not know a lot before, and they really touched on a lot of topics that I was interested in, like high-intensity gait training, and I think I learned a lot, and I really enjoyed this opportunity.
That's great, and you were only you just finished your second semester of PT school over at UIC. One thing that was brought up in the conference was the importance of professionalism. How important has your professionalism teachers over at UIC been to you?
Amazing. I feel like we've taught a lot of things that were brought up here, not only like dress code, but also just like how to interact with other people and how to interact with patients. And another thing they brought up was like how to like a lot of students outside of grad don't know how to talk to patients. So like practicing just simple things like asking for consent and things like that.
Communication.
Communication.
So whoever has taught you must have done an excellent job.
Oh yeah, he was awesome. He was amazing.
Awesome. At UIC.
Yep.
Thanks, Ryan. All right, I've got Ashley Crow from Ohio University. Not University of Ohio, two different things, which I just learned. Another thing that I learned from Bridge the Gap. Ashley, how was the conference? This is the last day. How was it for you?
Yeah, this conference was great. I have been able to come to all the Bridge the Gap conferences up until, since we've started. And so I really enjoy this conference. It's one of my favorites. It's really nice to be around a bunch of like-minded people.
Yes.
And it just sort of recharges my battery for the next year.
Absolutely. Now, Ashley, you work with a lot of DPT students. What type of information from this conference do you think would benefit for them to hear?
Oh, it's all of the evidence-based practice, and students they're thirsty for it. Mm-hmm. And so I'm excited to go back and look at my content and incorporate some of the newer and unknown to me into this moment information on like critical care and all of the evidence-based practice.
So hopefully in 2 years when we have Bridge the Gap again, hopefully we'll see more students because I think they could benefit a lot from this. Ashley, thank you so much. I have here Grace and Paulina who are gracing us in Chicago from Wisconsin. This is their first Bridge the Gap conference, is that correct?
Yes.
Awesome. How was it?
I enjoyed it. I really liked that I was able to come to this conference specifically since it was all acute care related, which is my practice setting. So everything was relatable for me in some way. I took a lot of good information that I feel like I can hopefully apply back at my settings. So it was very great just to do that and network, find people that are in your
like-minded
people. Yes. Very nice just to be able to be surrounded with that, I think. So a lot of fun.
I feel like stuff like when going back to work on Monday, a lot of the clinicians here are going to be able to implement their practice. What about you, Grace? How was the conference for you?
It was really amazing. So it's same thing with Paulina. We're working on the acute care, so it's applicable to most of the aspects, in healthcare. I mean, especially in acute care setting, and definitely very excited to share with our colleagues about what we learned here And yeah, it's great. And plus networking.
Absolutely.
You know, this is a great way to network and learning that you're dealing with things same way with other, you know, practitioners. So that's really amazing. So
Absolutely. I think those are some of the best conversations. Like, what do you do at your hospital? This is what we do at our hospital.
Exactly.
So thank you so much for being here.
Thank you.
Thank you. I have with me today the last lecturers from our Bridge the Gap conference, Laura and Kim. Their lecture, Movement is Medicine. How do you think it was received by the audience?
I think it was received pretty well. We got lots of response about, yes, this is what we're seeing and this is what we want to change.
I'd say what's nice is that the feedback that we seem to have gotten was that this is the right thing for the right time for the right patient, but then also that last push for how do we practice at the top of our license? How do we advocate for ourselves when we know that we need to change some of these things in the system so we can move stroke patients at the right time?
You know, I think it was really interesting is, Kim, you brought up a really good question. Is there a difference between mobility and rehabilitation, right? And some of the nuance behind that. And then also, I really love the quote, change the words, change the world. Could you explain that a little bit more?
So it's really one of those things where putting thoughts into actions is one of the ways that we can promote those changes, because it's one thing to just have it in your mind, oh, I wish, oh, I'd like, oh, if only. But one of the first ways to actually institute those changes is to talk the talk, so that way we can actually start walking the walk. Absolutely. And so just changing the perspective of how do we even see ourselves, how do we see our patients, how do we see our coworkers, by changing and by being very cognizant of the words that we use, we can empower those changes.
One of those, I will reference one of our former podcast guests, Jimmy Dyson, the words consult versus order. I thought that was really interesting. Are you consulted? Because those definitions are very different between that. Like you order labs, and they consult the cardiologist, they consult the nephrologist. And in terms of autonomous practice, I like the idea that we as clinicians, as physical therapists, we are consulted.
But that also holds a little bit more responsibility for us too, right? So at that point, we really have to make sure that not only are we practicing at the top of our license, but we also know what is behind that top for our license. So we become even more responsible for our own information at that point and how we use it. So it's one thing to say we are the best, but it's another way to know that we are the best.
Awesome. Well, thank you again for being the closers, the last lecture for our Bridge the Gap conference. It was a great success. Thank you very much.
Thank you.
APTA Acute Care has put out its 2025 call for nominations. Are you motivated to take a step into leadership within APTA Acute Care? The following positions are open: Secretary, Chief Delegate, PTA Member at Large, Education Chair, and Nominating Committee. Nominations close on June 17th. Please see our show notes for position descriptions and links to nominate yourself. And now, back to the show.
This is for our B-roll footage, extra bonus footage. So, Dan and I were talking, we were saying, he listens to the podcast, and I assume you're a subscriber? Yes. Awesome, we've got a subscriber. He wanted me to ask this question. We thought we should ask this question because he's got the same answer every single time. So when Dan listens to the podcast and when we ask in rapid responses, you know you're acute care win, this is his answer.
That nothing surprises you anymore in acute care. It is a rare day that I walk away from work shocked of something. Every once in a while it happens, but generally speaking, nothing surprises me anymore.
We've got good poker faces. Awesome. Thank you, Dan.
We would like to thank all of our Bridge the Gap guests for joining us on this episode of the podcast. Acute Conversations is the official podcast of APTA Acute Care. It is hosted by Leo Arguelles and Ashley Poole. Executive produced by Katie Brito and Edward Mathis. Music by Alexei Action from Pixabay. For more information about APTA Acute Care, be sure to check out our show notes for links and resources from the Academy. If you found value from our podcast, please be sure to subscribe, follow, and share with your friends and colleagues. Join us in 2 weeks for a conversation with our nominating committee. Thank you for listening, and may your shoes and scrubs stay clean today.